So my name is Sloane Guy. I'm a cardiovascular and thoracic surgeon at the Georgia Heart Institute at Northeast Georgia Medical Center in Gainesville, Georgia. And I'm happy to be here today. I am the director of minimally invasive and robotic cardiac surgery, and I'm here to talk about our research activities in cardiovascular surgery. I think that cardiovascular surgery is changing dramatically. There has been a huge emphasis on minimally invasive techniques, including transcatheter devices, both in valvular heart disease as well as mechanical circulatory support. Additionally, minimally invasive techniques such as robotics, I think, will have a larger and larger part of our specialty. Of course, there'll always be the traditional difficult cases that we need to do, and those will actually potentially get even more difficult and more challenging. So I think it's a very exciting specialty moving forward, and there's no doubt that it's changing from sort of a paradigm where we did surgery that has been around for many years to now doing more innovative procedures. So my research career has been a little bit different than a typical academic surgeon, although I was in academic medical centers most of my career, in that I was most interested in developing new procedures or better ways to do procedures. And so really more of an innovation focus rather than a basic science focus. Although I was formally trained in basic science, I did a lot of basic science research at the University of Pennsylvania in heart failure, surgery for heart failure. But the kind of things that I've been interested in did not fit the traditional model of academic research, in that they involved things like robotic tool development. So for instance, one of the problems that we found in robotic surgery is the difficulty in tying knots. You can tie knots, but there's some difficulty to it, and especially when you're doing open heart surgery with the robot. So I did a research project that was funded by the Department of Defense, where we helped develop a robotic arm that could automatically suture for you using the robotic arm, and it would actually eliminate knot tying by suture welding the suture together rather than having to tie it. So that's an example, I guess, of what you would call of translational research, where I identified a clinical problem, which is, suturing and knot tying in robotic surgery. I'm trying to figure out an easier way to do it, and I've helped worked with engineers to design a tool to more effectively deliver that. That has not always fit into the academic model easily, and yet some of our greatest advances in the field of surgery in the last 100 years have absolutely been in that category. So that's what excites me, is making better operations so that patients can have more effective operations or recover more quickly, or safer operations. That's always been my passion. And a lot of that has been around centered on robotic surgery because of my interest in robotic cardiac surgery and my active clinical practice in robotic heart surgery. Someone recently said at a national meeting, when I mentioned, the old guys were doing this or the old folks were doing that, they actually looked at me and said, "Well, I hate to break it to you, Sloane, but you're one of the old guys now." And so I guess I am that senior person now. But I actually think this is one of the most exciting times of my career. I have found that some of the most innovative work in the field of surgery, particularly cardiovascular surgery, is not always being done at the larger university medical centers or university research centers. It's often done at places like the Georgia Heart Institute, where we have a much more streamlined process to start a project, to get support for the project, to get funding for the project, to get IRB approval for the project, and to execute on the project. And so the irony is that some of the advances in some of the biggest advances in surgery in the past 100 years have actually come out of places like ours, where folks that are at, sort of clinically at the top of their game, which I like to think I am, are now taking that experience and putting it into innovative activity that actually is more difficult in a university environment than it is in a more streamlined research program like we have. I've been involved in teaching at some level my entire career, and I think that it's very gratifying to be able to teach others and share your knowledge, because let's face it, we're all on this earth for a brief period of time, and the next generation has to take over, and among other things, we're going to need people to take care of us. And that includes, medical students, residents, fellows. We have fellows here in cardiology, but also nursing staff, our first assistants, physician assistants, nurse practitioners, and teaching comes very naturally to me, and I enjoy sharing that knowledge. And I have no doubt that many of the people that I've taught over the years actually have surpassed me, and I consider that my greatest teaching accomplishment. A mentor of mine once said, always bet on the young. Young people come to the table with a lot of energy, enthusiasm, great ideas, and that's really been accelerated in recent years by, the rise of the information age that we're in, and the rapid transfer of information. And so what I have found over the years is that I have medical students, residents, and fellows that are very frequently interested in looking from an academic point of view and a research point of view, looking at the very innovative robotic cardiac surgical procedures and techniques that I have developed in the operating room. And we do some very novel things. For instance, we recently did the first totally endoscopic robotic aortic valve replacement in the state of Georgia. And that's very innovative, that's very new, and that's something that we should absolutely publish and get out there. And of course, it's great to have a resident or a fellow or even a medical student involved in putting together those publications. We also are interested in looking at series of things. So we have made in robotic heart surgery over the years what I call iterative changes, where, for instance, as an example, we wanted to get patients out of the hospital earlier than day 4 or day 5. We wanted to shoot for day 1 or day 2. And so I really broke it down and looked, what are the rate limiters to that? Well, the rate limiter is pain. So we started using cryotherapy to the nerves, so we'd freeze the nerves. Well, I want to have one of our residents or fellows or medical students actually look at that data and see, is it true? Is that actually helping move the needle on what we wanted it to do? And because that's valuable to others. So, and I think I was the first person to do this in robotic heart surgery in the country. If I am doing that and it's working, and we can document that and publish that with the help of the graduate medical education program, then that's something that's not only going to benefit patients here in Northeast Georgia, but it's going to actually potentially help patients across the country, if not across the world, because other surgeons will look at that and say, okay, well, they did X number of patients this way, and they had these results with that approach, and therefore maybe I need to do that. But you cannot do that without a research team, a team to help you put together the data, to help analyze the data, to get the institutional review board approvals, to write the papers, et cetera. And in the process of doing that with our graduate medical education folks, they also learn a lot, not just about that particular topic, but how to approach a clinical research problem and form a hypothesis, test that hypothesis with data, and present that. And of course, it gives them wonderful professional opportunities to present at national meetings and to publish in national publications. So the question I'm being asked frequently is, what is the most exciting, research topic you have at the moment? And I would say Number one at the moment is my interest in the robotic cardiac surgical team. So when you look across the United States at robotic cardiac surgery, it has not always thrived in many places, and I believe that one of the primary reasons is because of challenges with teamwork and team building. So that logically leads one to think that there must be sort of a team learning curve, right? There would be criteria that a team might have to have in order to launch a program, but as they're training and launching that program, one would imagine there is a learning curve that's really specific to the team, not just the surgeon. So I'm a very experienced robotic heart surgeon. I've started a number of programs successfully in robotic heart surgery. So I've sort of I'm still learning, but I've by and large been through the basic learning curve for a long time now. And so I'm sort of the gold standard, if you will. So the variable is the team. So one of the things I'm interested in looking at, and we've got actually a couple of our residents and fellows involved in this currently, is we are interested in examining the performance, the clinical performance of the team, not just the surgeon, but the team over our first 100 cases here. And I would like to compare that to the performance of the team in prior institutions after we had clearly been through the learning curve. In other words, the team was very mature and we were efficient and we were good at what we do as a team, not just the surgeon. Because I think that so many people that are not surgeons typically think of surgery as being the surgeon doing it. That's never true in any operation, but it is incredibly untrue when it comes to robotic heart surgery, because it is literally like a football team where there's people throwing the ball, people catching the ball, and the surgeon's an important part of that, but we are by no means the only part of that. So what we're going to be doing is looking at performance metrics, clinical and patient performance and outcome measures, things like operating room time or cross-clamp time, the time the heart is stopped, and we're going to try and see if that at what point does that sort of plateau and improve and reach the levels that it did at some of my previous institutions, because that will be a pure measure of the team learning curve. And while people have looked at surgeon and team learning curves before, in other words, a hospital is starting a new robotic program and nobody's done it and they're starting from ground zero, that's been studied at places like Cleveland Clinic and NYU. There's some great papers from there. To my knowledge, no program has looked at what happens when an experienced robotic surgeon goes to a new place and starts out of the blue. And then, because then the surgeon is not really part of that learning curve, it's really the team itself. I mean, you can argue some involvement of the surgeon, obviously, but by and large, it will be to demonstrate to the world, really, that in robotic heart surgery, the team performance is just as important as the surgeon performance. Another research interest that I have is in robotic tool and system development. There is currently, I would say, nothing short of a revolution or a renaissance of robotic system development taking place worldwide. For many years, there's really been primarily one company that made a robotic surgical system. Now, literally a month does not go by where even someone like me, who's an absolute robotic zealot, robotic surgery zealot, I hear about some company I've never even heard of developing a surgical robot system somewhere in the world. And there are a number of companies, we won't go through that, but there is definitely a movement within surgery towards robotics. Robotics is going to be a huge part. Artificial intelligence is going to play a big part. It already is being developed for robotics, where the surgeon might have things like augmented reality or little things like no-fly zone. Like if this is an area of the body that we shouldn't go, the robot won't allow us to go into that area. And these sort of human-robotic interactions are going to be huge. So I'm also interested in robotic system design. I was involved in a project with Johnson & Johnson and Google to help develop a surgical robot. Not many people know that on the grounds of Google in Mountain View, California, they were actually developing a surgical robotic system. And that's been turned over to Johnson & Johnson since then, but it shows you the level of interest that people have in it. So another area of interest that I have is the development of robotic catheter-based systems for structural heart disease. So right now there's a lot of work being done for transcatheter structural heart in the aortic valve space, mitral valve, and other areas, aortic aneurysms, etc. It is my ardent belief that in the future these will all be done with the help of robotic catheter systems that will help deliver those devices into the body more effectively. So eventually I would like to set up a really sort of a bioengineering effort here where we would have residents, medical students, residents, and fellows involved in robotic system and tool development at some level. And we've already begun some collaboration with the robotic research team down at Georgia Tech, where they have actually started pursuing some of these ideas. And so my hope is to eventually have some of our residents actually go and spend time in that laboratory armed with ideas and experience from the clinical world to interface with the engineers, because that's where the magic happens when it comes to innovation in biomedical engineering, is the engineer plus the clinician coming together with a problem and a tool and developing it together. And so I hope to develop that program here.